Okay, good evening, everyone. This is the second session for carotid cerebral vascular disease review for VSAP, the last edition, VSAP 5. So we're going to start, as I said, guys, in carotid stenosis, not much like clinical scenario. You have to analyze the data. Most probably you have just to review all the trials and know what the guideline and follow up this guideline to answer this question. All right, who wants to start? Let me see who's here. Bassam, you want to start, Bassam?
أهلين دكتور مساء الخير.
يا هلا.
السلام عليكم.
Yeah,
we'll start إن شاء الله.
All right, let's go and start so don't lose time. Okay.
A 69 years old woman presents with abnormal duplex findings on a workup for dizziness. The right internal carotid artery has 60 to 70% stenosis by duplex ultrasound, velocity criteria, and left vertebral artery demonstrates diminished flow versus near occlusion. The symptom most consistent with vertebral artery insufficiency is.
Okay. So what this question, they want just to know how to ask us what the symptom for posterior circulation insufficiency compared with anterior circulations, you know, because we get a lot of patients referred to us with the carotid stenosis, questionable stenosis because of his dizziness, and dizziness is not a sign of internal carotid artery stenosis, not a sign of anterior circulations, low flow. So you have to be careful. So here they want us to know what are symptoms of the anterior, what are symptoms of the posterior circulation of the brain. So let's start one by one.
Okay.
Go ahead, Sam.
Expressive aphasia lasting less than 5 minutes.
Okay, this is what, anterior or posterior?
It could be a symptom of anterior.
Okay, that's correct. So the reason why a patient comes with a slurred speech, you know, he cannot express aphasia. All this is a sign of anterior circulation. So this is a sign of internal carotid, not vertebral. Correct. Okay, next one.
Left leg hemiparesis occurring off and on for the past 3 months.
Okay.
If we say weakness or paralysis, then we'll say it's anterior, but this is on and off. So it could be a neurological symptom, but it's not related to posterior circulation as well.
Yeah, this I'm saying. They just want to know if it's anterior or posterior. That's all, Bassam.
Yeah,
it is the posterior or anterior circulation symptoms.
Anterior. Yeah.
It's anterior, correct?
Yes. Yes.
It's anterior. Yeah. Okay.
Okay. Right ocular shade obscuring vision. This is the amaurosis fogax. It goes with internal carotid artery, also anterior. Yes.
Correct.
This equilibrium, yeah, this one I think it goes with posterior, like dizziness.
Correct. Yeah.
And the last one is persistent facial droop. Also, this goes with anterior circulation.
Okay.
So the answer would be D.
Is D. So it's not a difficult question. So I'm saying, just want to know what the anterior and posterior. Most symptoms of the posterior circulation is ataxia, vertigo, dizziness, disequilibrium, headache, imbalance, you know. So this is kind of posterior circulation. Anterior circulation is, again, hemiparesis, hemiplegia, amniocephalogix, expressive aphasia, slurred speech, facial droop. So all that is anterior circulation, okay?
Okay, thank you.
All right, very good. All right, let's see, Muhammad, you want to take next question? Oops, sorry, oops, went too fast. We are 12 now. Muhammad, you are there? Let me see if it's there, Muhammad, or not.
Yes, doctor, I'm there. Yes. 12?
I can hear you now. Yeah, can you
Yes.
next question, please, Mohammed?
Yeah, 70 years old former smoker is seen 2 days after non-disabling ischemic left middle cerebral artery territory stroke manifesting with right arm and right leg weakness. A high grade of left internal carotid stenosis is identified. The optimal time to operate on this patient to derive the greatest stroke risk reduction benefit is.
Okay, that's before we go. So this patient, he's symptomatic and he has high-grade stenosis. So he's symptomatic internal carotid stenosis, high grade.
Yes.
So they want to know us what the best time to do a surgery. If you remember the guidelines, I don't know if you remember that the guidelines.
Yeah, I can't recall for this.
You remember how many? When?
What I know is less than 2 weeks.
Yeah, that's correct. So you know,
Yes.
that's correct. Less than 2 weeks.
Yes.
So you have to do within less than weeks, but not the first 2 days.
Yeah.
If you have a symptom within 48 hours, they found highest risk of stroke. So usually between 2 days to 14 days, you know.
Okay.
So you don't need an acute, but also you don't wait more 14 days.
Yes,
because they notice that if you wait more 14 days, the benefit really drops significantly. So they have a couple of trials for that. And this trial showed that if you do it within 14 days, every 5 patients you do for them, 1 patient will benefit. But if you do after 14 days, you have to do almost, I think, 125 patients to get 1 patient benefit. You see the difference?
Yes.
That's why it's very important to do it 14 days. Unfortunately, we don't apply that in our practice because you see patient, referred to us by the time he get admitted and we, see him in the clinic and do a surgery, it takes more than 2 weeks, But this is what the book said. This is what you have. This even the guidelines said within 14 days, This is the guidelines. Maybe I should put back the guidelines so we can remember that. But I need to open it. I know where it is. But in the meantime, let's go through the questions, see if I can find the guidelines. Go through the question and see what the answers.
Yeah, less than 2 weeks from the time of symptoms onset. I think this is the answer.
Okay.
The B, between 2 weeks and 3 months. C, within 24 hours. This is D, after MRI demonstrates stroke. E, not known. I think B is, A is clear.
Okay, so this is very, very obvious. I'm just trying to find the slide, guys, for the carotid. Let's see if we can open it. Just give me 1 second. Here we are. Yeah, stop sharing. Let me go and share again, but different. Here we are. Okay, see the slide, guys, again? Ahmed? All right, let's go to the guidelines. You see the slide, Muhammad? Hello, can you hear me? محمد تمام معي؟ محمد unmute yourself. بسام, can you hear me, Bassam?
Yes, sir. محمد يمكن مغطي clinic.
طيب, you can see my slide, Bassam?
Yes, patients who are to undergo revascularization within the first 14 days after symptoms onset should undergo carotid arterectomy rather than carotid stenting.
This and the other one, they said preferable within, if you want to do it, 50-90% as soon as possible, preferably within 14 days of symptoms. Okay, so this is the guidelines. Okay.
بس مش قايلين في الجايدلاينز انه within 2 days it's contraindicated?
Yeah, this is another trial. This is called European Carotid Surgery Trial and North American Carotid Trial. This is another trials. They found that the stroke rate, because this, you see, when they come to recommendation, they go through all their trial. And I just pick up the main one. I didn't go through a lot of details, you know. So if you go to the main guideline, you may find that, you know. Okay. The first 48 hours, they found increased chance of stroke. So they don't recommend to do it within 48 hours.
Good.
So the best way to do it within 2 weeks, but after 2 days. Yeah.
Okay, good.
All right, let's go back to our questions. Let's go to sharing again. Stop sharing. Share as a question. Okay, Amjad, you want to take that question? Can you see the screen again?
Yes, hi, Doctor.
Yeah, Amjad, شو أخبارك?
تمام الحمد لله.
Sorry. Okay. This is a 13, number 13. Sorry, guys, everything goes too quick here. Sorry, my computer, I promised my computer today. Well, let's stop. It's the best way to stop.
Sorry, I got a phone call, Doctor.
It's okay. It's okay. ما في
But Sam, he covered.
Samer, he answered that. Yeah. Okay, Amjad, let's go to 13.
Okay. A 61 years old man present with a sudden onset of the left side arm weakness. MRI showed an acute stroke. CT angiogram demonstrated less than 50% stenosis of bilateral internal carotid artery. The most appropriate treatment.
Okay, so this patient is 61 years old.
Disease.
Hmm?
So he's asking symptomatic patient with stenosis of less than 50%.
So 50%, do we treat it with surgery or with a medical treatment?
Symptomatic patient.
Yeah, but less than 50, be careful.
Usually medical.
Yeah, you see, this is what NASET said, all this trial, they said, less than 50, symptomatic or asymptomatic doesn't matter. You have to do it medically, you know. Only that is more than 50, symptomatic, you treat it with whatever surgery, stent, whatever. But all the trials showed, NASET trial showed that if less than 50, then they found it's not different in the stroke rate between medical treatment and surgery. So recommend medical treatment for less than 50, even symptomatics. Okay?
Samer?
Okay.
So let's see what they said here.
Samer? Samer?
Can you see that? Go ahead.
Yeah, can see it.
Dr. Samer? Dr. Samer? Dr. Samer?
Hello?
I think Dr. Ali is talking.
Sorry, I can't hear you, Ali. Go ahead.
Do you think that this question, we should mention this question, the nature of the plaque, if it is ulcerated or not?
Okay. Maybe when they don't mention that, you have to presume that this is normal, you know, it's just regular plaque. Usually, as you said, I mean, it's an exception for 50%. If patient persists, like if patient less than 50 and read medically and he still have symptoms, then you have to do it. But I'm talking in general, first time he come to you, do you have to try medical treatment? If the medical treatment failed and he's still getting TIAs, then even 50% you may do a surgery. Second thing, Dr. Ali talking about the plaque. Plaque morphology is the way it looks, a plaque, you know, if any ulceration or not, what the deep of the ulcer, A, B, or C. So all things you have to look for it. But for you, this is an exam question. Anything they don't mention to you, that mean is normal, because otherwise they will mention to you. So they don't mention to you the plaque morphology, you have to expect it's a nice smooth plaque, no ulcerations. So this is the way it should be for the question. But in real life, it's different. As Dr. Ali said, you have to look at the plaque. If he had a medical treatment and failed, then you have to reconsider it. But the trial, if we talk about just a trial, the trial showed 50% and less is medical treatment, even symptomatic patients. Okay, Ali? Okay, Amjad.
Okay. A, medical management with antiplatelet regimen, statin, tobacco cessation, and optimization of his cardiovascular risk factor. Yes.
Yes.
Diagnostic cerebral angiogram with the placement of self-expandable bare metal stent across the stenotic right internal carotid. No. TCAR by a low right neck incision with the delivery of self-expanding bare metal stent across the stenotic right internal carotid artery. Also no. Exploration of right carotid artery with endarterectomy and batch angioplasty for the stenotic right internal carotid artery. And E, I can't see the E, doctor.
Sorry, yeah.
Exploration of right carotid artery with external and internal carotid bypass using prostatic graft. So it will be A, medical management.
So this is what I'm saying. I mean, they just want you to know if you know the trials or not. And this is what the answer, less than 50. And this is usually what we do even our, when patient comes to the clinic, The only thing I don't depend on the ultrasound. I do a CT angiogram, which they did here to confirm. And when CT angiogram, yes, I look at the stenosis, I look at the plaque and everything and make a diagnosis. But if you go just with a question, less than 50% medical management. Any questions? No. All right, so this is what question 13. Ahlam, you are there, Ahlam?
Yes, doctor.
I'm going to take 14.
Okay, sure.
Show to you. Here we are. Yes.
Okay. The North American symptomatic carotid endarterectomy trial was a randomized controlled trial comparing carotid endarterectomy versus medical management for the symptomatic carotid artery stenosis, ipsilateral hemispheric or retinal transient ischemic attack or stroke. In patients with high-grade carotid stenosis 70 to 99, this trial demonstrated.
Wow, it's a tough question because you have to know the trials, and it's very hard, guys, to remember out of your, now. But I'll help you with the answer. We go one by one. But we know NACID. This is the one in 1995. The American symptomatic. We still follow up this one. 70 to 90% you need surgery, no question. This is what, if you have high grade, 70 to 90%, the trial recommend to do a surgery, not medical treatment. But the question I think to ask about the risk reduction, this is the top part of the question. If you go with this trial, as I'm saying, you have to remember this trial. The stroke reduction, it came from 26 to 9. So like 26 was a medical, 9 was a surgical. So 26 minus 9 plus 17. So there's a 17% decrease in the chance of stroke. The reason why they stopped this part of the trial early, really, because they have a result very obvious that people who had the surgery, they have a better protection. For ethical reason, they terminate this trial early, really. The moment they get a huge difference between medical and surgical, they finish this trial early, and they said very clearly that patients 70-90% symptomatic, he needs surgery. And you can see now we are 2021, and we still follow up this recommendation because it's very strong recommendation. It's 1A. So this is what exactly shows a significant drop from 26 to 9 percentage. So it's about 17% protection against absolutely risk reduction of the stroke. The second thing is that in this studies, they were talking only about stroke. They didn't talk about mortality, they did not talk about MI. The mortality MI is only talk about it when you go to CRISP trial, when we talk about the carotid stenting. But all other trial, they were looking only for stroke. So any question in this trial talk about mortality, talking about MI, don't get confused. Nothing to do with that. They just talk about stroke, okay? So let's go now with this two things in your mind. You can, I think, answer the question now. So let's go one by one.
Yeah, I think it's A. Carotid endarterectomy resulted in absolute risk reduction of 17, as you said, doctor, for any ipsilateral stroke over medical treatment.
Okay, but let's see why the other question is wrong. Let's go one by one.
Right. statistically significant improvement in overall mortality at 24 months for patients treated with carotid endarterectomy. We said stroke.
Yes, so we don't talk about this, so we don't know. They did not look at that. So it could be, I mean, you're right, but it's not what the trial said, you know? So it's not part of the trial, okay?
Yes. No significant difference in the combined endpoint of stroke, heart attack, and death between carotid endarterectomy and medical therapy. Again, this is not the endpoint.
This endpoint of what? Of CREST.
CREST, yes.
The one they compared stenting with a carotid surgery. They look at the stroke, heart attack, and death, and MI, really. So this is CREST. So this was CREST, this would be your right answers, okay?
Yes. Carotid endarterectomy resulted in a significant decrease in the epilateral stroke rate from 11 to 5% during the 5-year follow-up period. We said from 26 to 9.
Right. So this is right if it's asymptomatic. You see, you have to remember the asymptomatic. It's about the asymptomatic trials, you know, then like a VA trials, then yes, it went from 11 to 5 for asymptomatic. But for symptomatic went from 26 to 9, okay? So, so if it was asymptomatic, then this would be the right answer. You see, I give you that so you can remember, if they, because you may not get some question, same question, you may get different question, different way, you know? So asymptomatic trials, yes, it went from 11 to 5. Okay.
Okay. The preoperative stroke rate for carotid endarterectomy resulted in an overall increased mortality for surgical patients throughout the length of this study. No.
I mean, it could be right, I'm saying, but no, it's not part of the trial. Okay, that's good. So we go back to Muhammad. Muhammad, you still there or you still talking on the phone? Muhammad? No. Okay. So Sam, you want to take over, Sam?
Yes, no problem. A 55-year-old patient is brought to the emergency department by emergency medical services following the onset of left hemiplegia approximately 5.5 hours prior. Symptoms have remained unchanged since their onset. CT angiography performed upon arrival demonstrates complete occlusion of the right distal internal carotid artery. The therapeutic approach most likely to result in significant recovery of function is. So we are talking about acute stroke resulted in hemiplegia left side with CT finding of occlusion, acute occlusion of the right internal carotid artery distally.
Okay. So we know we have up to 6 hours, you know, you can do thrombolysis. Now some people, they change it up to 8 hours, and now even some people talk about 24 hours, you know. But I'm very sure everyone agree that at least 6 hours less you can do thrombolysis, okay?
Yeah.
We have an easy question for you if they put it this way, but they want to make it difficult, you know. So they can confuse, it should be give it IV or should be catheter-directed thrombolysis, you know.
Yeah.
So this is the main questions, you know. The time is different. You see, they did a trials to look at that, and they found if you have less than 3 to 4.5 hours, the clot's still soft, and you can do IV thrombolysis. After 4.5 hours, the clot become really thick, and thrombolysis will not, IV thrombolysis will not work. Then you have to do mechanical thrombectomy or catheter-directed thrombectomy. So this is the reason why they put 5.5 hours. So this is a tricky questions, and you have to know the timing. You have to remember this data, okay? So less than 4.5 hours, you can do an IV thrombolysis. More than that, up to 6 hours, then you do a mechanical thrombectomy, okay? So let's go through the question and see what they said.
Administration of a weight-based heparin bolus of 100 units per kg and initiation of a continuous intravenous heparin infusion. It's not an option. We don't give heparin infusion.
Right. We don't give it thrombolysis. We don't give
It will not affect the neurological function. That I mean.
Yes.
Okay.
Is that
Yes.
it makes your chance of bleeding if you give heparin, then you have to give thrombolysis, you know. So
Yeah.
that not to do thrombolysis, you don't have exhibition, you don't have thrombolysis, you know, then you may do it, you know. But this is not the treatment of choice. Okay.
Yeah. Okay. Close hemodynamic control of blood pressure to maintain systolic pressure less than 140. I don't think it will work. Yeah. There is nobody spoke about control blood pressure to improve the neurological function.
Okay.
This is after endarterectomy, yes, to prevent from hyperperfusion.
Okay. See, if the question is that what the therapeutic approach, most likely a therapeutic approach, then yes, you can give heparin, you can control blood pressure, but they want you, the question is result in significant recovery of function. You see?
Yeah.
If they put this sentence, then yes, you'll be right. You have to control blood pressure, you have to give heparin, you know, but they were looking for which significantly recover of function. Okay, this is a key on this question.
Yeah.
So, yes, you need to control blood pressure, but will not improve his function, recovery function, correct?
Okay.
Next one.
Intravenous administration of tissue plasminogen of TPA. As we said, no, definitely he passed 6 hours.
No,
so
you see,
it's 5.5 hours when he reached, but after CT, they took some.
Sam, don't presume something not written. They give you 5.5, that's it. It's not your problem what happened. You know, they want, so they will go with this time, 5.5 hours, okay? So because in Europe, it takes 5 to 10 minutes to get the cast, doesn't take 2 hours like here. So it's not a 5.5. Remember, we said it's less than 4.5 IV and thrombolysis will not work. But after that, up to 6 hours or even 8 hours, then you can give mechanical thrombectomy, okay?
Yes.
So will work. If they wrote like 3 hours or 4 hours, then yes, IV thrombolysis will work, will be right answers. But here they wrote 5.5. Okay. Because the trial showed 4.5. See, they want to confuse you. So the reason why they said catheter paid thrombolysis retrieval. Sorry, where is that? Tissue plasmin activator. This would be correct if they didn't write 5.5. They wrote like 3 hours, 2 hours. Then this would be. But 5 after 4.5 hours, then yes, no, this will not work. Okay,
yes.
so not. Okay, next one.
So if it is less than 4.5 hours or less, yes, TPA is indicated.
IV.
After that, yes.
No, all will be an IV. But this is IV intravenous. The other one will be retrieval, and sometimes they give a TBA. But the main thing, you need to retrieve it. You need to catheter direct. You have to take in the cath lab.
Yeah.
You give him in the when patient come to the ER, they give it in the ER. They give IV TBA.
Okay. The next one is catheter-based thrombus retrieval. So this is the best. This is the answer, not IV for this question. I mean,
plus 5.5 hours, correct?
Yeah. Administration of aspirin 325 milligram. No, it's not. It will not improve the function.
Okay. Okay, that's good.
So the answer will be catheter-based thrombus retrieval.
Yes. Okay. Man is still there or no?
Yes, Doctor, here. Yes.
Can you take next question?
Yes, sure.
Okay, it is number 16. You like? I'll get a question.
In the carotid revascularization in the arterectomy versus stent trial, a comparison of stroke risk at 10 years follow-up after carotid endarterectomy and carotid artery stenting showed.
Okay, before we go there.
Yeah.
Okay, so we talk about, because it's the most important trial really. This is the one, it with the carotid stent map. It's a very important trial. And if you remember in this trial, the only thing they have like this is a confusing question because they said 10 years, okay? This trial was for 5 years, but then they have an update on the stroke CREST trial after 10 years. So they want you to be really very updated. So the reason why you have to be careful, they put 10 years, not 5. Because in 5 years, it showed CREST trial that the stroke rate is higher with a stent than comparing with surgery.
Sure.
But they combined stroke, they found no difference, okay? But still the stroke is high. And you know, the cardiologists are very persistent. So they continue to follow up this patient, follow up this patient for 10 years. After 10 years, they found it's no different, even in stroke rate, you see? So they fixed their trial. After 10 years, they found it's no different in a stroke. But if they talk about 5 years, no, 5 years shows a difference, okay?
Okay.
So what the confusion in this question, okay? Even
Doctor,
after 10 years, they found even the mortality, you'd be surprised with the stent more than the surgery. And the reason why, because I don't know why, but I think because the stent patients are high-risk patients, so after 10 years, most of them, they will die more sooner than carotid surgery. So when they look at the mortality of 10 years, they found higher with the stent than surgery. But the stroke, they found no difference. But in 5 years, it was a difference.
Sure.
Go through this.
Okay. For the answer,
Don't go to answer. We want to learn just to go and answer. Go one by one and see why it's right, wrong, or right.
Okay.
You go
For A, statistically significant elevated risk of stroke with carotid endarterectomy and carotid artery stent compared to carotid endarterectomy regardless of symptomatic status. Okay, no elevated risk of stroke between them. So this is wrong. B, a statistically significantly elevated risk of stroke with carotid.
Is the noise from your side or somebody else? Noise.
No, it's on my side, I think.
Your side. Let me see. Maybe I need to. No, it's only me and you. Okay, I think from your side. Go ahead.
Yeah. B is statistically significantly elevated risk of stroke with carotid artery stent in symptomatic but not asymptomatic patients. Okay. C, statistically significantly elevated risk of stroke with carotid artery stent in asymptomatic but not symptomatic patients. Okay, this is, I think, the same answer. Okay, symptomatic and asymptomatic. D, non-statistically significant elevated risk of stroke with carotid artery stenting compared to carotid endarterectomy regardless of symptomatic status. I think D is the answer. E, equivalent composite of stroke and death for carotid artery stent and carotid endarterectomy. I think we said the stent has more mortality.
Yeah, that's wrong.
So D is the answer.
You see, it is a tough question because as far as I know, this is significant, but this is a 5 years. Now it's a 10 years. It's really confusing, these questions, you know. But be careful. In the exam, you may get like a 5 years, so you have to be careful. If the 5 years is, yes, it's a difference, okay? All right. Whose turn? Yes,
Doctor, but one question before we leave. And the SAM question, the catheter-directed thrombectomy retrieval,
yes.
It gets you the best functional once early. So if I have the patient and they have the facility to give tissue plasminogen, and they have like, I can do catheter thrombectomy, what I choose for like the first 3 hours.
First 3 hours?
Like the first 3 hours, and patient came after 3 hours, and they have 2 options. What I choose?
I think I will go. You are very right. Noise. Can you mute yourself, Muhammad? Oh, okay.
Yes, good.
Yeah. So what I'm saying is that I will go because TBA can give in the ER very quick. So I will do that. I will see if the patient improve, because they improve right away. In about like 15 minutes, you see like they wake up, they start moving. If you don't see improvement, then I may take him to the cath lab and do embolectomy. Thrombus retrieval. But if it's less 3 hours, I think I would try the IV TBA first in the ER. And we know that the half-life is very short, it's 10 minutes, so it's not a big problem. You can give it later on when you go for the cath lab. Okay? But
okay, doctor.
In indication, you can give it contraindicated if patient is very old, if he has a GI bleed, recent surgery, all the things. You have to look at all the things also, because direct thrombus retrieval at less risk of bleeding than IV, because IV is high risk bleeding through the vein. So you cannot give it if patient has recent surgery, brain surgery, GI bleed, very old, diabetes. Sometimes they said it's contraindication. So there's a lot of things you have to look for it, before you do it. So this also you have things you have to look at it when you decide which way to go. Okay.
Great, thank you, doctor.
So next question will be 17. Amjad.
Yes, doctor.
Yes.
72 years old man with severe emphysema, 4 liter per emphysema, 4 liter per minute, home oxygen supplementation, presented to the hospital with a right hand paresis, left facial drop, and a 2 centimeter left hemispheric stroke in the brain imaging. CT angiogram showing moderate 50 to 79% stenosis of the left internal carotid artery. His deficit improved, but do not completely resolve during the initial 4 hours of inpatient observation. The intervention associated with the lowest stroke risk is.
Okay.
So this is a scenario of old patient, fragile patient with a comorbidity, present with acute onset of stroke. The left side and with the left side stenosis, high-grade stenosis.
Okay.
With non-complete resolving of his neurological deficit within 4 hours.
Just a second.
So asking.
Different from the, this is not a thrombus. It's different from other question. Otherwise, was a thrombus. You have to go and retrieve it. This is kind of, because it's still within 4 hours, But yes, 50, so it's symptomatic. Now we're talking about symptomatic internal carotid artery stenosis, okay? We're not talking about acute stroke like the previous patient, okay? So this patient, 90% is indication, right? For surgery or stent, according to the, okay?
Yeah.
So what they want to tell you is that the intervention is the lowest. They want to ask about the timing. We go back to the timing again. And this is not the question which Bassam answered the first one. The best timing will be within how many days? 2 weeks, right?
2 weeks, yes.
14 days.
Intervention.
Yes. You have to avoid the first 48 hours. This is what our trial showed, increased mortality stroke if you do it within 48 hours. So usually between 2 to the 5 days, to the 14, 7 days, All right, well, let's say what's the question? We go one by one. So they want us to know what's the intervention rate with the lowest stroke risk. Okay, let's start one by one.
Okay.
Right or wrong.
Okay. Carotid angioplasty stenting within 48 hours of the initial presentation, still too early.
Yeah, I said 48 hours, we have to avoid this 48 hours, okay? So it's not, you have to wait at least 2 days, okay? Okay.
Carotid angioplasty stenting 2 to 5 days after the initial presentation.
Okay.
Still.
2 to 5 days after his end, could be, it's correct. Continue.
Yeah. Carotid angioplasty and stenting 6 or more weeks after his initial presentation.
Okay.
6 or more. Also, this can be correct.
No, the 6 weeks. We said 2 weeks,
6
right?
6 weeks.
We said
yes.
within 2 weeks. We said we have to do within 2 weeks. So 6 or more, this is 2. It's not the best, you know. They want to what the best intervention, what the best timing for intervention. We said within 40, so starting 6 or more weeks. Yeah, 6 weeks or more. No, this is too far. So this is for sure wrong. Okay. Okay, let's learn.
Carotid endarterectomy within 48 hours of initial presentation. Still it's early. Carotid endarterectomy after 48 hours, but within 14 days after his initial presentation. E, it seems sounds correct.
Okay, so E sound correct, but also B sound correct to me. Carotid angioplasty is sending 2 to 5 days after his initial presentations, you know. I mean, this is a bad questions, because I think they wanted to answer E because they like this 14 days numbers, you know.
Yes.
But they mean 2 to 5 is wrong, you know. The second thing is that you see patient, they said on oxygen, home oxygen and COPD, most probably I'll go with the carotid stent.
Yes.
So most probably I'll be question, my answer is B. But unfortunately, when you look at the answers here, let me see what's the answer. They put E. See? So it doesn't mean they are correct. As I said, I mean, the people who put the questions are people, you know, so they make a mistake. So I'm not, so this would be a confusing really question, very bad questions. But the whole idea is that less than 14 days. So I think E is correct and B is correct. And if you really want me, if so help with question, mostly you want us to answer B because why he put an emphysema and 4 milliliter oxygen. That means he wanted to tell you he's high risk for surgery, right? That's why he mentioned that. So really the more, you know, logic answer will be B, but they put an E. All right, but at least you get the concept that not between 2 to 14 days, 48 hours until 14 days is the best time for intervention, either surgery or angioplasty. Okay. All right, Ahlam, you want to take the question 18?
Yes, sir.
Go ahead, let's do that. All right.
An 81-year-old diabetic man with a remote history of prior stroke presented to the emergency room. According to his wife, who confirms the symptoms, he has a new 2-hour history of left hemiparesis and right facial drop. CTA confirms early ischemic changes, moderate severity. Intravenous alteplase at a dose of 0.9 milligram per kg, the maximum is 90, is indicated or contraindicated in this patient because.
Okay. Before we go, this patient is an 80-year-old diabetics, and he came with a stroke, huge stroke.
Yeah, 2 hours.
2 hours, okay.
Yes.
And you want him, can you give an IV TBA? Is that not indicated, you think? Within 2 hours?
Yes.
Yes.
We said up to 6 hours.
No, we said up to 4.4 and a half.
Yes, yes, 4.4, yeah.
But 4.5 hours, you can IV TBA. And this is a real dose. You have to remember that, guys. If you want, this is a regular dose, 0.9 milligram per kilogram, maximum 90. So this is a correct dose. So if somebody wants to memorize it, or if you get an exam, try to memorize these numbers, okay?
Okay.
So let's go through the question and see. So it's indicated. I think, in my opinion, in this patient, 2 hours history, acute TBA, stroke, I think it's indicated to give him an IV thrombolyzed TBA. So let's go. Okay.
So contraindicated due to the prolonged duration of symptoms? No, it's 2 hours.
Okay.
A contraindication due to the patient's age? No, there is no criteria for the age.
It is a criteria, but continue that. Then we talk about it.
Okay. Contraindicated due to the patient history of diabetes mellitus.
Okay, continue.
Indicated of combined with intravenous abeximab.
Indicate abeximab. This is
no
platelets. It's very, very strong. Platelets usually is a cardiologist to give it an acute MR. It's very aggressive antiplatelets, you know, very strong. So we don't give it to thrombolyze. You know, they give it in the MI, but we don't give it in stroke. Okay. So this is Okay.
Okay. Indicated because of less than 3 hours duration of symptoms despite age and history of diabetes mellitus. I think this is the one.
Yeah. All right. You need to remember more numbers. Okay. So let's do that. What they showed that less than 3 hours, you can give IVPA to everyone. Between 3 to 4.5 hours, you can give it, but you cannot give it for somebody more than 80 and has diabetes. So contraindicated.
Okay.
0.5 hours, you cannot give IV TBA. Then you have to go to retrieval, okay?
Okay.
Small number. So less than 3 hours, it doesn't matter his age, diabetes, you can give it. But after 3, I don't know why, don't ask me why, but this is what trial showed. 3 to 4.5 hours, you cannot give it if patient has diabetes or more than 80 years old, you know?
Okay.
So here, that's why they give you 2 hours here. You see, give you 2 hours here.
Yes.
2 hours history. This is within less than 3 hours. If they give you like 4 hours here, then we'll get you. And you cannot do it because the patient is 80 years old. You can give medication, and because he's diabetic. So 2 things: diabetes and high old age. You cannot give it after 3 hours. Okay.
Okay.
It's more confusing. 1 number, 2 numbers, but this is a carotid. You just have to remember that. You have just remember numbers. You know. Unfortunately, this is the way it is. Okay.
Okay.
The answer will be E. Indicate because less than 4 hours, despite his age and history of diabetes. You see. All right.
Yes.
Any question? All right, let's go to the next question, which is 19. Who's now? We go back to Bassam.
Yes, sir.
Okay, Sam.
39 years old man is involved in a motor vehicle collision with multiple injuries, including a cervical spine fracture and left internal artery carotid dissection, 3 centimeters above the carotid bifurcation. It is not flow limiting on computed tomographic angiography. Prior to discharge, he has severe episodes of transient expressive aphasia. Magnetic resonance imaging shows a perfusion-diffusion mismatch of the left brain. The most appropriate management for this patient is.
Okay, stop.
So, yeah, a young.
Carotid dissection.
Yes.
The limited is not like part of the aortic dissection. This is a carotid dissection, okay? And this is a traumatic carotid dissection. I think maybe Hamad Dahman, he see a lot of them now. He's doing his rotation in Shemasi. So how we treat carotid dissection after trauma? If patient is asymptomatic, the treatment is
medical, yes.
Yes, we don't do anything. Dissection is okay. It's like an aortic dissection. Patient asymptomatic, we treat it medically.
Yeah.
So the indication for intervene if he has symptoms, okay.
Yeah.
If he has an pseudoaneurysms,
yes.
Or aneurysm, they may develop aneurysms like the aorta.
Yeah.
What else? So aneurysm. If he has extravasation, interfere. So this is what else? What else?
Or deterioration of neurological function.
Yes, deterioration of neurological symptoms. Then you have to do it. I'm saying, yeah, become symptomatic.
Yeah.
But always we treat them medically. But if they when they come and they have no neurological symptoms, they will treat medically, and they will watch him. But like this patient, he gets several episodes of TIAs, expressive aphasia. They are symptomatic. Most of it is a flap opening and closing.
Yeah.
So when they become symptomatic, again, then we have to be fixed. So the question is that should be surgery or stenting? And this is a big question. Unfortunately, we don't have any data to compare because it's not very common. So it's personal. Of course, in young people, 39, you prefer to do a surgery, but if it is an Most of when you go surgery, do patch angioplasty or you interposition graft, or depend how bad the arteries, you know. You don't like with a stent, but sometimes, you know, if it's very high, like this one, they say 3 centimeters above the carotid bifurcation, you see. So
Yeah.
they want to push you to the stent. If this, because if it was lower, because 3 centimeters is really high, you can't get it with the surgery. So most of it try to push you here towards stent. But
Yes.
really the decision between stent and surgery, it depends on technical feasibility of the surgery. But if the surgery is feasible, in young people, always I prefer to do surgery, not stenting. Okay. All right. So let's see what the question. So this patient, he has a, you know, he has a dissection and he's symptomatics. Okay. So let's so one by one.
Continued anticoagulation with heparin followed by transition to an oral anticoagulation, anticoagulant.
Okay.
Yeah, it could be. نشوف الباقي. Let's see that.
That mean they want, this is a question that mean you're going to send him home with anticoagulant. He's getting TIAs. So that means
there is no indication.
So no, this have to intervene because it's symptomatic, okay?
Yeah.
The question comes that should we give him anticoagulant or antiplatelets? You know?
Yeah, I think it's enough to give aspirin and Plavix.
Yes, but the problem is there's no data. Because I'm saying it's very rare, so we don't have a strong data that lasts both. So I think you can go both ways. It depends on what you prefer, what you feel about it, and how is the patient's general conditions. But we don't have any strong data to tell us, no, it has to be antiplatelets, not different from carotid stenosis, because carotid stenosis, we have a large number of patients. Dissection is not money. So really you can go either way. You can go with anticoagulant or you can go with antiplatelets, okay? But you cannot do it because that if you say A is correct, that means you decide not to do anything and send him home with anticoagulant, which is not correct.
Yes.
Let's go next one.
Okay. Placement of an internal carotid artery stent across the internal carotid artery dissection. It looks like, it sounds good. I think this is the answer, but let's see the other options.
Okay.
Open carotid artery exploration with patch plasty of carotid dissection. I think it's not it's not suitable for this case because there will be no distal control. It's difficult to control it 3 centimeters above the bifurcation.
Correct. Yeah. Okay.
Open carotid artery exploration with carotid artery bypass. It's not suitable for this case. Ligation of the distal cervical internal carotid artery.
Yes. Do that. Sometimes if your patient comes with a dissection, extravasation, and the patient goes too high, you know, you explore him, then yes, you can do that. But of course, you have to be sure that patient has a good flow from contralateral limb. I mean, but sometimes too high, you cannot fix it, you know, with surgery or stent. And patient keep getting TIA, so you have to ligate it, you know. But again, you have to be sure that it's a circle of Willis, or you measure the pressure, retrograde pressure. You have to do something that can, otherwise you will end with a major stroke, you know. But this is one of the surgical options. But I tell you something else. If you look at the questions, what they say here, the question, see, every sentence in the question has a reason. They said he has a severe cervical spine fractures.
Yeah, so surgery.
Surgery is contraindicated because you cannot move his spine, because the surgery, especially with a carotid, you have to move his neck and lift it up and all the things, you know, especially if I dissection, you have to go really high. So this is another reason why here they want us to do a stent, not surgery, because cervical spine fracture and dissection about 3 centimeters above the carotid bifurcation.
Yeah, okay. So we'll choose B.
The second thing is a carotid dissection different from carotid stenosis. In carotid stenosis, always we use bare metal stent. In dissection, you can use both, either the carotid stent cover or bare metals. Mostly bare metals is enough, but sometimes if you have like, again, like an aneurysm or pseudoaneurysm, then you may use a cover stent. This is the only application you can sometimes use a cover stent in dissection. Okay?
Okay.
All right. Here, let's go leave the best to the last to the best. Let me see, 20. Okay, so Ahlam, you want to finish this night?
Yes, sir.
All right, cool.
46-year-old man has neck pain and is diagnosed with a spontaneous dissection of internal carotid artery extending to the distal cervical segment with a small associated pseudoaneurysm. The most appropriate management for this patient is.
Okay, let's stop.
So,
Patient has a section, the same things.
yes,
Okay.
spontaneous dissection, symptomatic,
Small
and
aneurysm.
pseudoaneurysm.
And really, I have a patient exactly like that. He came to me, I think, like last year, and we have, we discuss about what option we have and everything. So what do you think we need to do with this guy? He is asymptomatic, right? Let me see, any symptom?
Even neck pain.
Success is the right side with a small associated. Yeah, neck pain is not a symptom of TIAs or anything, right?
No.
Neck pain.
Yes.
But he has a dissection and small pseudoaneurysms. So should we treat it or not?
Antiplatelets if symptomatic, stenting.
But he's not symptomatic.
Yeah.
So,
So medical. Antiplatelets.
Usually this patient, this happened with my patient, the same I did. We did him an antiplatelets and we watched him. Because like an aortic dissection, if we see the pseudoaneurysm start increasing inside, then yes, we have to put a cover stent, but if the pseudoaneurysm stay the same or decrease in size, then we can just watch him. And in our patient, we watch him for almost now 2 years, and the pseudoaneurysm is decreasing by itself, So this especially that's small. We want to push you toward the conservative management because they say that's small. It's not a big pseudoaneurysm. If it's a big pseudoaneurysms or symptomatics, then yes, I will do it. But it's just a small pseudoaneurysm with a dissection and patient completely asymptomatic, I think I will manage him conservatively. Okay?
Okay.
Let's see what the question said. Let's see if we are...
Antiplatelet therapy only if the patient becomes symptomatic. No, asymptomatic, we start antiplatelet.
Correct. So not only. We put them
not
on.
Only. Yes. Anticoagulation alone is indicated in all patients with internal carotid artery dissection. Alone, no. No antiplatelets.
Okay. Go ahead.
Stent placement due to risk of endovascular stent due to risk stroke, no. Endovascular statement placement is indicated for symptoms or if serial imaging shows increasing stenosis, so the aneurysm growth or aneurysmal formation, yes.
Okay.
Urgent surgical reconstruction, no. So it's D.
It's correct. So yeah, this is a very nice. And again, I have one patient like that. So you see it's not very common. So we did the same. We just decided to watch him and watch him again for 2 years, and he's fine. He's completely asymptomatic. But again, you cannot just send him and you have to watch him. All this dissection people, you have to follow them. I think we forgot to mention that. You have to follow them with a serial ultrasound, or because they may develop aneurysm later on, or pseudoaneurysms. So all patients with a carotid, internal carotid, if you decide to treat them medically, then you have to follow up with the ultrasound or CT angiogram, especially if you have pseudoaneurysm or aneurysm or something like that. Okay.
Okay.
I think we get to 20 questions. Our time is over. I think we're done for today. You have enough, guys, today. We'll continue next week.
Thank you.
Question from anybody in the group? Let me see. We said, when should we intervene in traumatic carotid dissections? We talk about it. We should intervene if patient become symptomatic or pseudoaneurysm or aneurysm or extravasation. This is, I think, the main indication for intervening in traumatic carotid dissections. All right. So no more questions?
Doctor, but just to clarify, if I have patients with stenosis, asymptomatic, like 70 and 60, or 60, both sides are 60. How to follow up this patient? How frequent?
How frequent?
Yes.
I do it within, I mean, first when they come to me like that, first you do CT angiogram as a baseline because it's good accurate, right? But then I follow up with the ultrasound. I do it once a year. I think once a year is more than enough. Yeah. Because you see, carotid stenosis, they don't get worse very rapidly. It takes a long time to get worse, you know? So usually our practice here once a year, you know? And if I see stable over many years, maybe do it every 2 or 3 years after that.
Okay.
Okay. Any other question? Ali, you want to add anything, Ali? You have a lot of experience with these things.
No, thanks. But I would like to ask, can anyone mention to me what are the zones in the trauma of the neck?
Wow.
How can we divide? How can we divide
The zone?
Because, yeah, how many zones we have? How can we divide it in the trauma?
Okay, see, the best one to answer is Muhammad Dahman. He's doing a trauma now. Also, he read about it. I'm sure Isam assuming. So Muhammad Dahman.
In base of this, we can choose. In base of this, we can choose the best treatment of these dissections. And when you have a dissection about 3 centimeters from the bifurcation of the carotid artery, at in this case, we are at the border between zone 2 and zone 3. So the stent is, I think, is mandatory when you have to treat.
Okay,
yeah,
so
we have three zones, doctor. The first one, zone 1, from thoracic inlet to cricothyroid membrane, and the second zone from the cricothyroid membrane to the angle of the mandible, and the third zone, which is the difficult one to open or to see, is from the angle of the mandible up to the base of skull. This is the free zone, and yes, we will find the carotid bifurcation at zone 2, but 3 centimeters above in the internal carotid, it will be in zone 3. So it will need a lot of manipulation to get good access there.
Yeah, it is at the border between zone 2 and zone 3. So
yes,
you have to operate in this case. You have to dislocate the mandibula, no?
Yes, sure.
So the stent, I think, is better. I think this will ensure the idea that the stent is better in this question that they ask.
I agree with you.
To use it.
And because you see, as you said, 3 centimeters is the borderline between zone 2 and 3. And to solve the issue, so nobody now get confused, what they tell you in the question, they say he has a neck fractures. So this way they push away from that, because they knew that if you put only 3 centimeters, somebody may question, as you said, may do surgery standing because of the border, you know. But when they put has neck fractures, then I think now we have to talk about stenting. No way you can do a surgery, especially if you want to high, you have to dislocate the mandibles, a lot of manipulation in the neck. And this is contraindicated when you have a neck fractures.
So the stent choice is a
yes. So the stent, in that scenario, I think the stent is the best scenario for this sad patient. Yeah.
Sure. Thanks.
No problems. Okay. Thank you guys again, and we'll meet next week. Take care. Have a great night.
Thank you.